last week, and now we're getting into osteoporosis. So the rest of block 3 is kind of going to be in that endocrine realm, right? Osteoporosis is in that realm, and we'll talk about why with the parathyroid hormone. So without any further ado, once again, medications up front. If we get to the thyroid lecture today, I owe you the medications on the front end. I'll get that added. And then I also have some check on learning questions for headaches, and I'll probably post, every few days I'll post some for each of the lectures. Normally 4 or 5 questions only, because with the check on learning, just like we did in GI, Pharm, and in GI proper, I'll give you like 4 or 5, because when I tell you the right answers will tell you why, and the wrong answers why, just like on the pants or the pantry. So you're really getting about 4 or 5 questions out of each question. So, and especially when we, like today's lecture, there's only like 30 slides. So anything more than 4 or 5, and I'll be left without anything to test you on, right? I'm sure I can find something. But so the medications for the thyroid, I'll post when we get to that, and probably later this afternoon or tomorrow. So here's your roadmap of the meds for osteoporosis. Not a lot in this lecture, but the medications are very specific in each class as to what they do. So the learning objectives, basically understanding a little bit about the pathophys of osteoporosis, but we're not going to delve too deep, just deep enough to where you understand why certain medications and supplements like vitamin D and calcium and their utilization in osteoporosis. So just some definitions up front here. Osteoporosis is when the creation of the new bone does not keep up with loss of bone. And we're going to give you some diagnostic criteria through a DEXA scan here in the upcoming slides. A little bit of a review. Hopefully you recall it from A&P. So osteoblasts are the cells that make bone. And then osteoclasts, I think of with the C, they cut, right? They break down bone. They are responsible for bone reabsorption. So you need to be aware of osteoblasts versus osteoclasts, because the different medications that we use for osteoporosis are working on one or the other, right? Either helping make new bone, so they work on the osteoblasts, or they can impede the breakdown, so they can work on the osteoclasts. And so the parathyroid hormone in the neck, backside or right by the thyroid gland, that's going to control calcium, phosphorus, and vitamin D in the blood and bone. It keeps the balance between those. So basically, calcium in the blood controls what the parathyroid is doing. If you have low blood calcium, then you're going to release parathyroid hormone, right? To put some calcium out of the bone back into the blood. And then the opposite. If you have high blood calcium, then PTH is going to be blocked. But it does matter if that parathyroid hormone is acting continuously or intermittently on bone as to what it does. But the normal action of the parathyroid hormone, low blood calcium, causes it to kick out PTH, so we're going to pull some calcium out of the bone. And then high blood calcium is the opposite. Block PTH so that we don't leach calcium into the blood from the bone. So you have to understand that concept to understand some of the medications. And then there on the bottom right, that is just a diagram saying exactly what I just said in words. So the DEXA scan. So the gold standard for diagnosing osteoporosis is the DEXA scan, right? So not calcium levels, not vitamin D, all those things. DEXA scan, gold standard. So it's going to measure bone mineral density, or kind of more appropriately, lack of. So when you see the T-scores, you need to know these values for osteoporosis. They will be on your pants, for sure. So if it's greater than or equal to a -1, that's a normal finding for a DEXA scan. Greater than or equal to -1. So more positive. right? Because sometimes it can be confusing when you start talking greater than or less than when you're dealing with negative numbers. So greater than, so a larger number than -1 or equal to -1 is normal on a DEXA scan finding. Less than -1, so more negative than -1, to up to -2.5, that's osteopenia. Not osteoporosis yet, but a loss of bone density. So the diagnostic name for that is osteopenia. So less than -1.0 up to greater than -2.5. And then if we have less than or equal to -2.5, so more negative than -2.5, that's osteoporosis. And then less than or equal to -2.5 and having a fragility fracture, i.e. you've got weak bones, so you have a spontaneous break in that bone, or fragility fracture, then that's going to be severe osteoporosis. Everybody tracking on those numbers and what they mean? So severe osteoporosis is that more negative than -2.5, and they've already sustained a fragility fracture due to their weakened bones. So this is just an overview you can come back to, but all the medications we said we're going to discuss in the lecture, this is just showing where they act, in what pathway. Whether they're working over on the osteoblasts or they're affecting the activity of the osteoclasts, the cutters, the cleavers, the ones that break down bone. And we said the osteoblasts make bone. They're bone makers. And then you see where all the medications are there and what they're affecting. So you can always come back and review this when we get to each of the different drug classes. So osteoporosis, weak, brittle bones, right? So over on the left, we're talking about what's normal and then how it affects all the different functions in our body when it's abnormal. Highest risk for osteoporosis, postmenopausal women, due to loss of estrogen production. So estrogen protects bone. So postmenopausal women don't have high enough levels of estrogen anymore, so that's why they're most at risk for this disease process of osteoporosis. Lifetime risk is there, women 50%, men 30%, so it's not just a disease of postmenopausal women. In the U.S., about 10 million people greater than 50 years of age have osteoporosis, and about 34 million have osteopenia, differentiated by their score on the DEXA scan. So definitely know those numbers by heart. So low estrogen puts you at higher risk for osteoporosis. Yes, both men and women, more so women, but men can have decreased estrogen as well. Increased age, too many birthdays is a risk factor, right? So why? Because we don't absorb calcium the same as we age. So increased age is going to put you at higher risk for osteoporosis due to that reduction in calcium absorption. Or you can have a calcium deficiency proper, which is going to increase your chances of osteoporosis. And we'll talk about how much daily calcium is recommended to prevent osteoporosis. But yeah, decreased or deficiency in calcium and vitamin D can put you at a higher risk for osteoporosis. And then also the increased parathyroid hormone secretion due to something like an adenoma or vitamin D deficiency, which causes that increased PTH secretion. Well, we said the parathyroid hormone is going to cause what to happen to the calcium in the bone? Be pulled out into the serum, right? So, therefore, if you have a tumor in the parathyroid gland causing your body to release, or the parathyroid to release too much parathyroid hormone, then you're going to leach calcium out of the bone into the blood. So, what do we do to treat it? Not a whole lot of drug classes, which is good, but most of them are pretty specific actions of what they do. So, who do we start with for pharmacological treatment. Once we get that diagnosis of osteoporosis, T-score less than equal to negative 2.5, or they have that history of a fragility fracture, we're going to initiate treatment. There's also a risk stratifier known as FRAX. That's what you see on the third bullet. So you can have not quite the T-score for osteoporosis, but a T-score for osteopenia, and you have an increased risk by that questionnaire, the FRAX questionnaire. We'll also we'll start pharmacological treatment there too. So know the reasons why we start pharmacological therapy. But don't forget the first bullet, lifestyle modifications. Very important adjunct here, weight-bearing exercise, those kind of things to strengthen the bone. We'll get more in depth when we go through each of these options for treatment. Also, calcium and vitamin D, foundational for the treatment options for osteoporosis. For all of the treatment options, you have to have normal levels of calcium and vitamin D for the medications or the pharmacological agents to work in osteoporosis. So always, always, always start with getting the calcium and vitamin D to the levels they need to be at before you put on any of these medications, such as the next bullet, the bisphosphonates. Easy to pick them out of a lineup because most of them end up with the suffix, right? The ronates. The bisphosphonates all kind of end in the same suffix. Kind of easy to pick them out of a lineup. Only one of them do not, and that's the IV option there on the bottom, which we'll talk about, the reclass or the zelodromic acid. But most of the bisphosphonates end in there. Easy to identify suffix, the dronates. We also have an anabolic agent. This is the only one that actually builds bone. The rest of them are anti-reabsorption. The teriparatide of Forteo is actually a bone builder. It's an anabolic agent. And then we have for osteoporosis, we have a monoclonal antibody, just like we've talked about monoclonal antibodies for a couple of different disease processes. We talked about them with migraines for treatment and prophylaxis on last week. But here, there's only one, so you need to be able to recognize it. It is a full human monoclonal antibody that inhibits rankle, and we'll talk about what exactly that means and what it is. So denosumab, MAB at the end of it, it's a monoclonal antibody. But you need to know the full name of the drug there, denosumab. We also have a nasal spray or injection, calcitonin salmon, that we can use for osteoporosis. We'll talk about its limited efficacy. And then finally, we're going to talk about SERMs, or selective estrogen receptor modulators. Since we said postmenopausal women are at higher risk because of decreased estrogen, right? Because estrogen is bone protective, then there are some limited uses for estrogen replacement in osteoporosis, and we'll talk about what those uses are. Don't forget about your foundational calcium and vitamin D before you initiate anything pharmacological for osteoporosis, and make sure that you understand lifestyle modifications are going to go right along with your medications. So lifestyle changes. Encourage adolescents, young women to build bone early in life, to start with a good foundation, right? Before the estrogen goes away in menopause. Also, you have the values there, recommendations for intake of calcium. Most adults, about 1,000 milligrams a day. And then for females, postmenopausal, we up it. And also males over 71. So we've mentioned we can't reabsorb calcium as we age as good as we do before we get elderly or of a certain age. So we bump it up for women 51 years or older, and males about 200 more milligrams a day. And then for the vitamin D, there's a foundation there. The Bone Health and Osteoporosis Foundation recommends vitamin D 400 to 800 international units a day for anyone under 50 years of age, and then up to 800 to 1,000 for older adults. Incorporate weight-bearing exercise such as walking and isometric exercises such as weightlifting early, young, adolescents. Build a strong foundation to maintain strong, healthy bones so that when the estrogen does start decreasing, or in our males, when we also start to not be able to absorb calcium as well, we have a strong foundation to start with if we have to do pharmacological therapy. Avoiding excess glucocorticoids. We've talked about that at length. We talked about it in last block, what the side effects of prolonged glucocorticoid exposure can do to bone. And then, yes, smoking, not good for osteoporosis, and limit alcohol. So you don't have to memorize this chart, but we're basically just going through the foundation, right? The recommendations for elemental calcium and vitamin D. And then there's two sources. There you see for the vitamin D, calciferol and orgocalciferol. And then we're going to talk about calcium on the next slide. There's a couple of options for calcium as well. So for the vitamin D, we either use the D2, the ergocalciferol, or the D3. D3 is a little more potent, so that's generally preferred. But either is okay. But the cholecalciferol D3 generally preferred for your vitamin D supplementation. And then just know that the calcitriol is the active form of calcium and vitamin D. There on the bottom. So calcium, primary mineral of bone. It's called hydroxyapatite when it's in the bone. Calcium, primary mineral of bone. 1,200 milligrams a day, optimal for calcium daily intake. Too much supplementation has been shown in some studies to have some bad cardiovascular outcomes. So limit it to about 1,200 milligrams, as it says on the slide. That's your optimal dose or your optimal intake. So the key difference between the two calciums is that the calcium carbonate is going to require gastric acid, so it's best with meals. But if you have a patient who is elderly, or patients that are on antihistamines or the histamine blockers for reflux or PPIs, go with the calcium citrate because it does not require gastric acid. Just some minor differences, but hugely important when you start thinking about doing the calcium supplementation, because if you're taking the calcium carbonate and you're depressing your gastric acid, you might not be getting much out of that, much absorption out of the calcium that you're supplementing with. So the citrate not requiring gastric acid, better for your folks on PPIs or your elderly patients. Adverse effects of calcium, both brands, constipation or decreased absorption of other drugs. And as I said, anything over that 1,200 milligrams, we start thinking, is there a increased risk for cardiovascular events, or specifically MI? You need to be aware of that adverse effect on the bottom. 1 second, sir. I'll get to you. Always separate calcium from levothyroxine, which we're going to talk about in depth during the thyroid lecture, tetracyclines, and fluoroquinolones. So be aware of those adverse effects. Question, sir? Yeah, and we're going to talk about that in an upcoming slide, how much you're getting from just, there's like a slide which shows how much you're getting with the intake of like tuna versus salmon or versus, I'm not going to ask you about them, but it's there for reference. But I'm sorry, was there another part to the question? Yeah, they may not, right? It might be that if they're having a diet, and we're going to go through that, like that's you as a clinician sitting down, maybe keeping a food diary for someone who's at risk for osteoporosis and discussing, okay, you're eating this, this, and this, or more than likely you're not taking, a teaspoon of cod liver oil every day, or not eating canned tuna with every meal. So yeah, you have to discuss what they're taking in their normal diet versus how many milligrams they would need. So it needs to be like 1,200 from all sources, not just from supplementation. on top of somebody who eats fish 3 meals a day, 7 days a week. Okay, like I said, make sure you're aware of the adverse effect of taking calcium. So you just separate it by a couple of hours from if you have a patient on levothyroxine, and we'll talk about what its use is. Like I said, that's a preview of things to come when we talk about thyroid. And then tetracyclines, you should be aware of the antibiotics, and then fluoroquinolones, those antibiotics. But that's a good board question always. So you just separate it by a couple of hours. And here you are, sir. This is discussing the vitamin D. So we can do the 800 international units a day, and you see there it says all sources. So yeah, a food diary may help if you know that your patient is at risk, or perhaps maybe already has osteopenia, or is already diagnosed with osteoporosis. Kind of have to talk to them about their diet to get what they're taking in orally in their meals, and then offset that so that they get to, for vitamin D, the 800 international units a day via all sources. Yes, sunlight will help you increase your vitamin D, but then you have the whole risk of skin cancer, so really try to get it through the diet or supplementation. A lot of folks are getting enough in their diet, but if not, consider adding in supplementation to get them to where they need to be for the calcium or the vitamin D. So the indication for vitamin D, either the D2 or the D3, prevent osteoporosis, or if your patient has a deficiency, and then we're going to talk about its use in hyperparathyroidism and chronic kidney disease at a later date, beyond the scope of this lecture. And once again, we're just repeating ourselves with how you can get there, right, for vitamin D. Vitamin D can be toxic. Greater than 5,000 international units a day can cause toxicity of vitamin D, which can lead to hypercalcemia and hypercalciuria. So you can start getting those changes from too much calcium in your diet, but also you can start putting stones into the kidneys. So don't want to be up near that toxic range. Stick to what the recommendation is, about 800. So 800 international units a day is a lot different from 5,000, right? That's a whole lot of calcium, vitamin D. All right, moving into the first drug class we're going to discuss today, the bisphosphonates. First line therapy. They're the first we're discussing, they're first line. This is your first line in osteoporosis. Bisphosphonates. And like I said, bisphosphonates ends in ATE, actually NATE, and so do all the drugs but one in this class. And they're there on the left as available products. The IV option is the zelendronic acid. That's what makes it different in the class, is that it's IV. So what did they do? Basically, they're poison to the osteoclasts. They prevent osteoclasts from functioning. So I think of it as the bisphosphonates are a poison to the osteoclast. They shut them down. So they bind to that hydroxyapatite, the calcium in the blood, or in the bone that we discussed. And so then when the osteoclast tries to take it up, they don't function because they're bound by the bisphosphonate. So the osteoclast is shut down. And then your body's going to go through apoptosis, so basically it's going to get rid of that, right? It's going to get rid of them. So basically bone reabsorption or bone breakdown by the osteoclast is shut down with bisphosphonates. And that's all the bullets on the left are saying, right? They work by decreasing osteoclast activity. Decrease reabsorption, thereby increasing density, and that helps to prevent fractures. Long half-life in the bone, years in the bone. That's why we're going to discuss about some of the special things with patient management, timelines on bisphosphonates and such in the upcoming slides. But just know there's a long half-life. Once you have them on board, they're there interrupting osteoclast activity for a long time, for years. So first line in patients with osteoporosis, highly effective of reducing both vertebral and non-vertebral fractures. So that's important. When we talk about some of the other classes of medications, we're going to discuss if they prevent fractures or worsening osteoporosis in the vertebra, or the hip, or only the hip, or only the vertebra. If they decrease pain versus do they build bone or slow down osteoclast activity, so preventing bone breakdown. So it's important to know that for the bisphosphonates, the reason they're first line is because they can reduce vertebral and non-vertebral fractures. However, their caveat is poor bioavailability. Very, very strict administration rules. If I was betting, I would certainly put everything I had on that question being on the pants. If you look at the bottom right, the administration rules for bisphosphonates. Has to be an empty stomach. Recommend a full glass of water, let's say 8 ounces, so a full glass of water, and the patient has to remain upright for 30 minutes after they take it. And then the patient must wait, for most of them, at least 30 minutes before you can take any other medication, whether you can take anything orally. No food, no drink, at least 30 minutes. You have to wait for almost all of the bisphosphonates. We'll talk about the exception, and that's the next bullet. Ibandronate is 60 minutes. So you have to wait for that guy for a whole hour before you can take anything else in. So you need to be familiar with all of the administration requirements for bisphosphonates, because if the patient doesn't follow them, the bisphosphonates are not going to work due to how poor their bioavailability is. Yes? Yeah. It's not in addition to the sitting upright. It's concurrent. So start the clock, 30 minutes. Okay, you can, I guess, lay down, but you wait 30 more minutes before you eat. Right? So it's 30 minutes sitting upright, and then 60 minutes total before you take anything else orally. And if you don't follow the rules, especially like the staying upright, you can get some severe esophagitis, inflammation of the esophagus. If you lie down, the medication can cause severe esophagitis. Yes, sir. So we're going to talk about the specific ones and where the cutoff is for renal considerations. And then there's some other medications that we consider. So the question in the room for the juniors, if you didn't hear it, was just asking about the renal dosing considerations, and we're going to hit that in the upcoming slides. So when we look at the clinical use, like I said, first line, you need to know the exception there, ibandrolate. So it's the exception to the 30-minute rule for eating, right? And then it's also an exception for what it can reduce fractures of. You see on the slide in bold there, the ibandrolate is only vertebral, whereas I told you as a class, the bisphosphonates are vertebral and other bony locations, not just the vertebral spine. So know those exceptions for ibandrolate. Pharmacokinetics, long half-lives, up to possibly 10 years. Therefore, we usually say drug holiday after 5. Drug holiday after 5 years. So consider 10 years if they have the severe osteoporosis, and you will see that under pharmacokinetics there. Now, experts recommend treatment for 5 years, but 10 years if they have that femoral neck T-score less than negative 2.5, so it's osteoporosis still, right? Or they had those previous vertebral fractures or multiple vertebral fractures. So you need to know the number right. Generally, contraindicated creatinine clearance less than 30. So as a group for the bisphosphonates, less than 30, then we renal dosing considerations, and we're not going to give, it's an absolute contraindication for the bisphosphonates as a class. We're going to talk about what you can use instead in the upcoming slides. Adverse effects. So the GI ones are pretty severe. The acidic regurgitation is the main reason why folks are sitting up in a chair for 30 minutes, right? And why you can get esophagitis if you don't follow the instructions on how to take them. Gastritis, esophageal ulcers, dysphagia. What's dysphagia? Pain or difficulty? There you go. All right, and then abdominal distension. The two big ones are the next two bullets. Osteonecrosis of the jaw, kind of a big deal, right? Losing your jawbone is an adverse effect, usually associated with folks with getting dental procedures on the bisphosphonates, or they have cancer, or after prolonged therapy with the bisphosphonates. And then the last one is the atypical fractures or esophageal cancer. Interestingly enough, that the current FDA recommendations, as it shows on the slide, is to continue to use the drugs if you're diagnosed with esophageal cancer, but following the dosing instructions. I'm not going to get that down in the weeds. And pants, I don't remember them ever getting that down in the weeds on it. But definitely the osteonecrosis, the GI adverse effects, and atypical fractures with an increased esophageal cancer, you need to know those. All right, and then the administration rules. Like I said, know them all, own them, love them. You're going to see them again. So this is just breaking out the different packaging and how it's prescribed and presented and packaged. Like I said, in here, I don't need you to know the dosing for the bisphosphonates. Do know that the zoledronic acid, right, the one with a different name that's IV, reclassed, is once a year IV. So unlike the bisphosphonates, which, as you see, there's lots of options depending on which bisphosphonate you choose. For prevention, there's a dosage, there's a treatment dosage, and it can vary from daily to weekly. So there's lots of options with dosing. A lot of that could be based on if your patient is adherent to those administration rules, right? The eating, the sitting upright, taking first thing in the morning. But just know the zoledronic acid is the one that's IV, and it can be given once a year. And this is just a chart, which basically just shows everything that we discussed. I pointed out already the highlights I need you to know on the slides. But here's a good way, a good central location you can look at for all the different bisphosphonates. Remember the creatine clearance less than 30 for the entire class. So if you learn that, bisphosphonates, if the creatinine clearance is less than 30, it's contraindicated for the entire class. Everybody, right, in the class, all of them. Okay, now we're moving into our anabolic agent. Unique, right, teriparatide. All the other drugs that we're going to talk about, including the bisphosphonates, are anti-reabsorptive, right? They stop the breakdown of bone. Teriparatide is anabolic. It builds bone. So would it be working on the osteoclast or the osteoblast? Blast, B for build, right? C for cleave. So yes, it is working on the osteoblast. It's an anabolic. It builds new bones. It is a recombinant form of human parathyroid hormone. What did we say parathyroid hormone does to bone? It pulls calcium out, right? So why are we giving a hormone that is a recombinant form of our own body's hormone that breaks bone down? Because I told you in the beginning that it matters if it's continuous versus pulse dosing on the bone of parathyroid hormone. What it does, when you give it in burst dose, and we'll talk about that, it actually helps to build bone. It's the continuous exposure which actually leads to the increase in osteoclast activity. And so that's why dosing is important with teriparatide. If we give it as it's scheduled, it's like a daily, and that daily input is what's going to help build bone versus what the parathyroid hormone normally does, which is increases osteoclast activity. And it's there under mechanism of actions, right? It binds to the PTHR1 receptors and it stimulates osteoblast activity, increasing bone turnover, mass, and strength when it's administered intermittently. Continuous equals bone loss, like we have when we have low calcium levels normally in our body. PTS continuously affecting the bone, PTH rather, which is going to cause osteoclast activity. So when do we use it? Look at the numbers, right? We're getting really severe. High risk of fracture and a T-score of negative 3.5 and below. And we already said that that puts our patients, early on when we're talking about diagnosing osteoporosis, that puts our patients in that severe category, all right? Or patients can't tolerate the bisphosphonates is when we're going to use it. We also use it for glucocorticoid-induced osteoporosis, and it's costly, about $42,000 a year. So that may limit some of the clinical use. You know, if insurance is not paying and your patient has to cough up $42,000 a year, they might be better with compliant with the $5 med that just requires holding off from eating for half an hour and sitting upright. I would get in line with that plan real quick if they said it was $42,000 to be able to eat, you know, right after I took a medicine. So adverse effect: nausea, dizziness, headache, leg cramps. There is an increase of cancer, and therefore in bold right there, you need to know, love it, own it forever. If you use teriparatide, 40, 2 years, that's it. So we said we can use it for the patients who are unable to tolerate bisphosphonates. Well, they're going to have to get tolerant after 2 years because you can no longer use it. So hopefully with the teriparatide, we build the bone up in those 2 years so that we move out of that high risk of fractures and our T-scores over negative is more positive than negative 3.5, so they can be treated with the bisphosphonates. Because when you stop the teriparatide, all the bone that you just made, if you don't get an anti-reabsorptive on board, i.e. a bisphosphonate, it goes away rapidly. Rapid bone loss, rapid increase of risk of fractures if you stop the teriparatide and don't get an anti-reabsorptive on board. Whether they made it the whole 2 years or whether they were on it for 6 months. Any bone built with the 40 has to have an anti-reabsorptive added in when you change therapies, or else the bone is rapidly lost. So yep, I wrote it down. Make sure you discuss PANTS. Is going to ask you about stopping the teriparatide, the anabolic agent. Move to an anti-reabsorptive. Most likely, most commonly, first line, bisphosphonates. Or else it's rapidly gone. You have some contraindications there: hypercalcemia, hypercalciuria. Why? Well, we're building a whole bunch of bone, making a bunch of calcium with this steroid. So if you already have elevated levels of calcium in your blood or in your urine, well, we don't want to also make more and now put you at risk for kidney stones. There is also a contraindication for a risk of osteosarcoma, bone cancer. So if your patient already has some type of metabolic bone disease, avoid it. Also avoid it in patients that may have had some kind of skeletal irradiation, right? If they were exposed to radiation therapy skeletally, then you avoid this steroid, teriparatide. Well, I guess my clicker decided to stop working here. Okay, so this is just pointing out, it's back the same slide, but notice where teriparatide is over there below the osteoblast precursor, because this is the only one that's building bone, working on the osteoblast. All the other medications include the bisphosphonates, as we're discussing, work over on the osteoclast side, preventing bone reabsorption. So now we'll move into rankle inhibitor. New class. It's a powerful anti-reabsorption anti-reabsorptive agent. And denosumab, or Prolia, sub-Q medication, it blocks a rankle ligand. What rankle is, R-A-N-K-L. It's a primary signal that's going to tell the osteoclast precursor cells. So if you go back to where we were showing, it says OC precursor. What the rankle is going to do, it's going to tell the osteoclast precursors to mature and activate, right? Rankle, that's what it normally does. Rankle inhibitor, what does it do? Inhibits that. So it inhibits the differentiation of those osteoclast precursors from becoming osteoclasts. And you can go back and look at that chart and see it, or it's blown up here on the right for you. But by blocking the osteoclast activity, it just it prevents, unlike the bisphosphonates, which is poison to the osteoclast, the rankle inhibitor, denosumab, it prevents the osteoclast from ever becoming one, right? The precursor cells never become osteoclasts when a rankle inhibitor is put into the system, because rankle is what differentiates those precursors to become osteoclasts. So because it ends in MAB, we know it's a monoclonal antibody, but this one is not working at CGRP, right? It's working at rankle. So it's a monoclonal antibody targeted for a specific receptor. And rankle is in the TNF receptor family. And if you want to know, down below you can read all about it, but it's a transmembrane soluble protein which is essential for the formation, differentiation of precursor osteoclast cells into real live osteoclasts to help break down or reabsorb bone or cleave bone. So what does it result in? Bottom left, decreased bone reabsorption because the osteoclasts aren't made, or less of them are made, and increased bone mass and strength. Clinical use, not a lot of data. It's a new drug, right? A lot of these monoclonal antibodies are new things. And I think I've said, I'm not sure in this classroom or some of the other classrooms, but like when you're watching television, every other commercial now is some new monoclonal antibody, whether it's for osteoporosis, migraine prevention, psoriasis, gout, you name it, rheumatoid, not gout yet, but rheumatoid. So all of these targeted specific monoclonal antibodies, really a lot of them coming to market through science to say, hey, we don't have to use these broad spectrum drugs that can lower immunity globally or have a lot of systemic side effects. We can use targeted synthetic antibodies that actually monoclonal antibodies that actually go in and do what we want to do at the cellular level. So it's exciting, but it just means us future PAs just have a lot more drugs to learn about, right? So that's okay. So we just stay up with what's happening, but all of these new monoclonal antibodies are exciting in the treatment when you've treated kind of the old way with things that have a lot of side effects and that are very limiting. So who do we use it for? It is a good first line option, especially, once again, our patients who can't take bisphosphonates. What did we say about a lab for renal function? What's our cutoff for bisphosphonates? Right. So, denosumab, Prolia, you can use it less than 30. So that's why if they can't take the rules for taking the bisphosphonates, or if creatinine clearance and their kidney function is less than 30, you can use it, because this medication, being a monoclonal antibody, it is not cleared through the kidneys. So because it's a first line, works pretty well, and if the patient doesn't have the kidney function to take the bisphosphonates, this is what you would use, right? So once again, just like with the steroids, if you stop it, you got to have an anti-reabsorptive on board, right? So not intended to be used as an osteoporosis prophylaxis or for osteoporosis in premenopausal women. Initial therapy, we're going to say those with high risk, as you see on the left, kind of middle of the slide. So if they can't take the bisphosphonates, or there you go, markedly impaired renal function, less than 30 milliliters a minute, then we're going to give it. You still monitor their kidney function, but definitely not a absolute contraindication below creatinine clearance of 30 as the bisphosphonates are. Adverse reactions. Most common, back pain, musculoskeletal pain, can increase your cholesterol, and cystitis, so inflammation of the bladder. Serious issues, they're not very common, but serious adverse effects would include hypocalcemia. Usually this is folks that already have chronic kidney disease. You might have chosen this medication because they have chronic kidney disease, but you have to watch out for a serious adverse reaction of hypocalcemia. Or if we have over-suppression of bone remodeling, then we get into the adverse effects. That same as we have with bisphosphonates, right? That osteonecrosis of the jaw or fragility, atypical fragility fractures. We can have an increase of serious infections for folks that are on the denosumab, and so we have to monitor for that. And that's just due to the immune suppression, mild immune suppression, because it's a monoclonal antibody, right? So it lowers it a bit. And also dermatological reactions, as you see there, which ones, the eczema, dermatitis, we have to monitor for those, but they're not very common. No to pregnancy. No pregnancy, cannot use this medication. And if you have hypocalcemia, it's contraindicated. And much like we talked about earlier, when you stop this medication, abrupt cessation without a follow-up therapy, i.e. an anti-reabsorptive agent, the bone loss is going to rapidly go away, and then your patient is a higher risk for fracture, increased fracture risk. And usually it's like multiple. Like if you put somebody on this medication and you stop it cold turkey and don't put them on an anti-reabsorptive, it's just like a little bit, it's not like a little bit of fracturing, it's like a shower of fractures. So definitely hugely important for dosing considerations and patient management. So this is where we're at. Okay. So we're moving on to calcitonin. Good time to take a break. We'll kick back off at 1400. All right. So we have about 8, 9, not a whole lot of slides left on this lecture. And the next lecture is thyroid. I was going to start it today, but what I think we'll do is just kind of end this one out, but just be prepared to dig deep tomorrow in thyroid, right? So we'll, this isn't a lot to chew on, but you have plenty served to you tomorrow in thyroid. So I think we'll be okay to just finish up. And I don't know what everyone has going on at 1500 as far as the next instructors, but I'm tracking no one. But if someone was supposed to be coming in or on call, you might want to give them a heads up that I got like 15 minutes left. All right. So next class of meds, calcitonin. It's a hormone. We said we only had one medication that works on the osteoblast side. What was that? What medication? Teriparatide. So calcitonin is a hormone, weakly inhibits osteoclast activity. It does come as a nasal spray. Its effect on bone density is minimal. It is not a first line. Hasn't been shown to reduce fracture risk significantly or consistently, and there is an increased risk of cancer with long-term use of calcitonin. So the thyroid gland naturally makes this peptide hormone, calcitonin. We get it, and what it does is antagonizes the effects of parathyroid hormone. So we talked about what the teriparatide does, right, versus what the calcitonin does, because unlike the synthetic kind of form of the parathyroid hormone that we can give intermittently dosing to cause bone build. Now we've got calcitonin, which is going to antagonize the normal parathyroid hormone function, which is to increase osteoclast activity at the bone. So calcitonin is going to antagonize those effects of our normal parathyroid hormone causing bone reabsorption or calcium reabsorption. It lowers the serum calcium by inhibiting the osteoclastic activity and bone reabsorption, both vertebral and femoral. Not useful for pelvis or hip, and we do get some of the products from salmon. More potent and longer lasting than our own human calcitonin, interestingly. Does have some analgesic effects. Have we talked about analgesic effects with any other class of medications for osteoporosis today? Not really, right? So, analgesic effects, calcitonin. We mentioned what the mechanism of action is, and it is not first line. Its only real role that you need to know about is short-term treatment of pain from acute vertebral compression fractures. I say again, the only real role you need to know about calcitonin is short-term treatment of pain from acute vertebral compression fractures because of its analgesic property. It's normally going to be a distractor on your pants because of that niche role. It's not going to be a primary form of primary approach to osteoporosis for pharmacological therapy. And it's bold there in the middle of the slide. Only benefit reducing pain from osteoporotic fracture. Does not produce sustained increase in bone mineral density. So there you see the FDA indications on the bottom left. Osteoporosis, women more than 5 years post-menopause. We can use it for hypercalcemia. That's got nothing to do with osteoporosis, usually. Paget's disease or bone cancer. So, like I said, just know that niche indication. There are some adverse effects. The oral product can give you nausea and flushing, and then nasal spray, anything as an inhalant can give you runny nose, right? Or rhinitis. Does, like I said, increase rates of all cancer in numerous studies. And you can get tachyphylaxis with prolonged use. What does tachyphylaxis mean? Your body's not responding anymore, right? To the medication. Efficacy stops. So now we're on to the final class in osteoporosis as far as pharmacological management goes, which is estrogen replacement therapy. So estrogen, as I mentioned at the top of the lecture, is an inhibitor of bone reabsorption. But with menopause, it goes away. So that's why it's a primary driver of postmenopausal osteoporosis, because estrogen is not there to assert that inhibition of the bone reabsorption any longer. So yes, estrogen replacement is effective at preserving bone. However, systemic risks are huge. Venous thromboembolism, stroke, breast cancer. So these side effects usually outweigh bone benefits for osteoporosis. So what does that mean? Not a primary therapy for osteoporosis. Not a first line. And you can see there that estrogen replacement therapy on the slide suppresses osteoclast formation, it inhibits bone reabsorbing cytokines, reduces bone reabsorption, and net effect is preservation of bone mass. And then we talked about a couple of times now that after menopause, with those estrogen levels dropping, why now we don't have the protective effect on the bones. And the systemic risks are huge, and that's why it's not our first line or in the first line thoughts for osteoporosis. But we will talk about the SERMs, the selective estrogen receptor modulators, when we have an estrogen deficiency, usually postmenopausal. So the SERMs are selective estrogen receptor modulators like raloxifene, which will be on the next slide, or Evista, so raloxifene is kind of the class representation. They are designed to provide the benefit to the bone without the risks of estrogen to the breast tissue and the uterine tissue, which is great, right? So raloxifene is estrogen agonist, so it acts the same as estrogen on the bone protective, that's good, that's goodness, and an estrogen antagonist in the breast and uterus, also good, two good things, right? So also when you have the higher estrogen dose, as you see on the slide, the higher the increase in the bone density overall. Not first line clinically. The long-term risks of estrogen replacement outweigh the benefits in osteoporosis. Always consider other therapies first. Usually, and used primarily, if you're going to use estrogen replacement therapy or a SERM, postmenopausal women, and then the bone protection is secondary. Low dose is going to help control the vasomotor symptoms that you get with menopause or premenopause. Beyond the scope of the class, but basically the primary use for SERMs or estrogen replacement is going to be the menopausal symptoms, the vasomotor symptoms, not osteoporosis. The risks of estrogen replacement therapy: breast cancer, endometrial cancer, as I mentioned, venous thromboembolism, and stroke. So the risks are high, they are real. So those are your contraindications as well. Also contraindicated in pregnancy and using hormones, or a history of either breast or endometrial cancer, or undiagnosed genital bleeding, and like I said, pregnancy. So raloxifene is the SERM representation, and as I said, get the benefit of estrogen without the risk of breast and uterine cancer. So the clinical use, pretty niche, right? But it can reduce vertebral fractures with little effect on the hip. Does not affect raloxifene, does not affect breast and endometrial receptors. It can help improve lipid profile, decrease CAD risk. You do need to know about the drug interactions for the SERMs, or raloxifene. Bile acid resins decrease raloxifene absorption by 60%. Warfarin is the big one because it decreases your prothrombin time by 10%. So big interaction between raloxifene and warfarin. And then we'll talk tomorrow about thyroid hormones. And you have to separate estrogen treatment from thyroid hormone treatment by half a day, by 12 hours. And there we have the risks for raloxifene, as I mentioned, that you need to be aware of. The hot flashes, the venous thromboembolisms, or stroke. That brings us to the memory jog. I won't read them to you. They're a good foundation to steer you where to dig deeper at. Like I said, not a lot of drugs to memorize for the osteoporosis, but they are niche. So since there's so few drugs and drug classes, I would pretty much know everything about the drugs that are used to treat osteoporosis. And then I will hang out for like 10 minutes if there's any questions, and I'll walk over to the junior classroom for the same. I will post probably the 5 headache questions, 4 or 5, this afternoon. And then as we go through the lectures, I'll post more, probably 2 or 3 from today's because it's such little material, but hugely important material. Don't let it sneak up on you during the test or the pants, because even though it's not a lot of material, I mentioned a lot of these are pants pearls that you'll need in your career and to get the C behind your name by passing the pants. All right, thanks.